Welcome to AMSA Talks. This is for July 2024. We're with Amy Watson and Leah Pope. It's our first coming back AMSA session for a while, after a break for a while, but we're here with some friends and new faces, and we're going to talk about 988 and 911.
Great. We can just do quick introductions, and then I'm going to present some slides. So hi, everyone. Nice to see and meet some of you. I'm Leah Pope. I am currently an associate professor in the psychiatry department at Columbia. I'm an anthropologist by training, so most of my work is qualitative in nature. And I used to work at the Vera Institute of Justice with Jackson Beck. So good to see him here. And I'll just let Amy say hi.
Sure. So, hi, everybody. I'm Amy Watson. I'm a professor at Wayne State University. I've done a lot of work related to police response to people experiencing mental health crisis, and have been very fortunate. There's now the opportunity over the past 5 or 6 years to really look at alternatives to police, relying on police for this. So, Leah's going to talk about some work that she really led. I was very fortunate to be able to have a small piece of working with her on it. But I've also been doing some evaluation work looking at 988 and mobile crisis teams in Illinois, and also looking at 911 in Milwaukee. It's good to see many of the folks I haven't talked to in a while. It's good to see everybody.
Great. So I prepared some slides today to talk about our work in New York State, looking at 988 implementation and collaboration with 911. And I'll go through those to provide a high-level overview, but I definitely want to leave a lot of time for discussion. And I'll just say at the outset that this has been really a 3-year research project that we are now completed, but it involved 2 phases that I'll talk to you about. So I think when Jason reached out to us, he had read an article in Psychiatric Services that we wrote that really looked at perspectives on when people think they're going to call 988 and 911. And that was done in anticipation of the launch of 988. And then we continued research after implementation, looking at how 988 and 911 were collaborating. I'm going to talk about both of those pieces today, and then we can open it up to discussion. Okay, great. So I'm just going to jump right in to talk about these 2 phases of research. We started research in 2021, knowing that 988 was launching in the summer of 2022. And we really, at our first stage on the left, you can see we had pretty broad research questions. We didn't know much about 988, despite being in the crisis space for a long time. And we really were thinking about the fact that this new line was launching, and yet there wasn't necessarily a lot of discussion about who should be calling this line, right? So it had been the National Suicide Prevention Lifeline, which in its title had suicide, and so that kind of gave one sense of who to call. And then they were rebranding as the 988 Crisis Lifeline, and there was a sense of, well, we think it should be a broader set of callers, but what does it really mean to have a crisis, and who's going to be calling this line? And so we wanted to ask kind of how are stakeholders in different parts of the state defining a mental health crisis and the support they need? And then how do they think they're going to make decisions about calling 911 versus 988? And then once we finish that phase, which I'll talk about in more depth in a second, we really wanted to dig into 988 versus 911 and how those collaborations were happening, and what barriers existed. And so we focused on 3 counties in this, or actually more than 3 counties, but 3 areas. So Monroe County is in the green, the small, on the western side of the state. That's where Rochester City is. Then in small southern part of the state is Westchester County. That's a suburban county. And then we initially focused on Essex County, which is part of the red. But we ended up widening it to North Country because of the way their 988 is set up. So their 988 is set up as a regional call center encompassing 4 counties. And it was intentional to choose an urban, suburban, and rural county structure for this project, because we really wanted to understand how 988 was being implemented in these different locations and geographies. but it ended up being somewhat fortuitous in the fact that we didn't know at the time that they had very different structures for their 988 call centers, as well as probably more importantly for the purposes of this project, for their 911 operations. And so that has provided a nice natural experiment in qualitative terms, if you will, about kind of how 988 and 911 collaborate. And I'll tell you a little bit more about those differences in a minute. So in our first phase, we did 15 focus groups. And then in our second phase, we did site visits to call centers, both 988 and 911 call centers. We observed dispatcher training and 911 diversion training. We also observed the mobile crisis response team in Westchester County. And then we did 24 interviews with kind of leadership at 988, 911 mental health providers. So you can see here the focus groups. We did stakeholder specific focus groups. So in each county, we would have one focus group with mental health providers, a separate one with crisis call takers, consumers, families, and community members, so on and so forth. And that was really to give stakeholders a chance to speak among their peer set, to really talk about the questions we were asking, which at the time were really more about how they defined crisis, what supports they need or they think people need during a crisis, and when they think people should call 988 versus 911. So we talked to 76 people across these 3 regions. And this is a very high level schematic of what we found. But it was clear at the time, remember, this was before 988 launched. So people didn't necessarily know about it. And in fact, most of the people we spoke to had never heard of 988 when we did these focus groups. There just wasn't very much discussion about it. And I'm not sure if that was the case in your states, but certainly in New York, they were very intentional about not advertising 988 prior to launch because they didn't want to confuse people. And they weren't exactly sure what they wanted the public messaging to be. So we did a little bit of education during the focus groups. We naturally had to, since people didn't know. And then people, given kind of what we told them, they responded back to us how they thought they would use it, or in the case of crisis call takers or providers, how they thought people in the community should use it. And so you'll see on the left kind of what people identified as reasons to call 988. Immediately talked about kind of mental health support. And that was a pretty wide range of what they thought that meant, right? It could be people identified things like, if I'm having a bad day, I'm going to call 988. And then on the other end of the spectrum, people said, if I'm in crisis, thinking about or, actively self-harming, I'm also going to call 988. So people had a pretty broad range, and certainly at the consumer level represented that full range of when 988 was an appropriate call. The other reason people thought about calling 988 was that they wanted and hoped, in sort of an aspirational sense, that 988 would be able to connect them to resources. And that could be something as specific as I, want to find a mental health provider in my region, to I ran out of my prescriptions and my prescription medication and I need a refill, to I'm looking for housing support. So it was more of those kind of tangible resources that people were looking for. And they went beyond mental health, narrowly defined, really more of a social determinants of health perspective on people wanting resources. And then we had people who were very explicit about using 988 as an alternative to law enforcement. And that was really brought up independently, this sense that people had had bad experiences calling police in the past for mental health crises and thought that maybe this could be an alternative. And I will note that, in some cases, people were also reflective to say, that, maybe that's the goal, but in my community, I would need that alternative to exist in order to be able to call 988 to access it, right? So in some places, particularly in North Country, mobile crisis, for example, is not readily available. And so they talked about wanting to be able to call 988 as an alternative, but understanding that might not result in an alternative at the current moment. On the other hand, people were also pretty articulate that they thought that 911 still had a role in crisis response in their communities. And there were sort of two big buckets. One was, at least in New York State, there are certain things that law enforcement must do according to statute. And those are things like mental health related pickups or transport. So if a mental health provider wants law enforcement there, they're required to come for transport. And then there was this other bucket that we call like the safety concern bucket. And this, as the term implies, is super vague, right? Like, what does it mean to be unsafe? And we tried to push people on what they meant when they thought someone needed to call 911 because of safety concern. And it was really interesting. So for providers and crisis call takers, there was a general kind of reliance on more clinical language, things like imminent risk, harm to self, things that they know that they already practice when they involve law enforcement potentially. Consumers, the language was vaguer and a broader range. So one person, a few people actually said that they would only call 911 in life or death situations, right? Which is a pretty high bar for when you would call out law enforcement. On the other hand, some people use language like a person being uncontrollable or out of hand, just kind of their innate sense of when they thought that they couldn't handle it, and they thought that they might need to call law enforcement. So I think you can see here kind of, this idea that people at least before 988 launched saw a real need for 988 and lots of uses, also still considered that they would be using 911 in their community for a subset of situations. So then we moved on to the second phase of work, where we did interviews. Again, we went to each of these sites, we did site visits, we participated in trainings, or observed trainings, and then we interviewed different officials in the county, whether they were 988 leadership or call takers, 911 police, mobile crisis teams, or county mental health officials. And again, the idea here was really to probe more about that 988-911 interface, and to really understand what was going on. How are they triaging calls? How do they send out responses? What sort of communication just generally exists across the two lines in terms of collaborative mental health response? And what resources do they need to improve what they're doing in their counties? So I'm going to just show you two maps. You can see right off the bat that they're different. Part of what we did was to really map out how calls are routed in each of these locations. And not surprisingly, they are routed really differently depending on where you live, right? And they use different tools, different triage tools, different questions to make those decisions. So I'm going to highlight some of the key differences in a minute using a table, which will be a little easier. But briefly, you can see here that in Monroe County, New York, there's 911, there's 988, and then there's 211. Which you may or may not be familiar with, but in Monroe County, the 211 provider is the same provider as the 988 provider. So they have the same number, you call different numbers, it goes to the same provider, but it has different call takers. But they use very similar processes of connecting with the caller and assessing risk. And then depending on how that assessment goes, they can resolve on the phone. They can send out mobile crisis directly from 988, or they can call the person in crisis team, which is Rochester's alternative civilian response team. Separately, if you call 911, there's a very structured process in Monroe about how calls are triaged, which I'll talk about in a second. Westchester County, totally different. Westchester's a suburban county. And you can see they have 988 as well as their crisis prevention response team, which was existing before 988. They now also answer the 988 call line. And then on the 911 side, they have lots of local police departments who are answering calls. So depending on where you live, your call will go to the state police or to the local police department. And all of those different agencies are making their own triage decisions. So we heard this quote during one of our interviews, and you've probably heard it in your own work if you're working all the places you guys said you are, but just this idea that if you've seen one PSAP, public safety answering point, you've seen one PSAP. PSAPs are organized really differently depending on where you live. So I just wanted to summarize some of the differences that we saw here. So in Monroe, again, the largest urban county that we looked at, they have a centralized emergency communication center that sits in Rochester, and all emergency calls, all 911 calls go there first. They have professionalized telecommunicators and dispatchers, which are two separate jobs. So people can move up, so to speak, in the career ladder, but you have to be a telecommunicator before you're a dispatcher. And they use a specific triage tool, the EMD medical card set, which is part of the ProQA software. So when someone calls in, they have a very standardized set of questions to ask that person. If it's a mental health related call, for example, they go specifically to card 25 and they ask a series of questions. And Monroe has gotten to a point based on a lot of planning where they, depending on the code the call gets, they divert to different resources. So a call could go to 988, it could go to their person in crisis team, or they have another team called the forensic intervention team, or it could go to law enforcement. And those aren't really individual dispatcher decisions. They're supposed to be made based on the code that the telecommunicator assigns to the call. Now, a dispatcher can always override it, but the idea is to be as structured as possible in assigning who gets what response based on the agreement of lots of stakeholders about what kinds of calls can receive non-law enforcement response. Really different than Westchester, as I pointed out. They have 39 different public safety answering points. And so who answers your call? It could be a civilian call taker. It could also just be the police officer who's on shift on the desk that day. They answer calls depending on how their agency answers calls, which is in most cases a pretty unstructured approach where the call taker or the police officer is just asking the person kind of what's going on. However, they have implemented a 911 diversion protocol that they are trying to roll out to all agencies, all the different public safety answering points. And that is essentially a tool that, assesses people as low, medium, or high risk based on questions that are similar to kind of a standardized suicide assessment scale. And if they're low risk, they can be diverted to the 988 line or the crisis prevention response team. Or medium risk, maybe have co-response, which exists in several of the areas of the county. That has been challenging because when you're dealing with 39 different agencies, you need to get buy-in from everyone and different people need to be trained. So there's a larger issue there about sustainability. But ideally, they have the infrastructure and capability and go ahead from the top level in the police to say, we will do this. And then in Essex, that shouldn't say in progress, that I should have deleted that, but they have, North Country has, we looked at Essex only within North Country. We weren't able to get in touch with all of the other county level 911 centers. They were very behind on 988 implementation. So our research kind of lagged there, in part because they were trying to develop this regional structure. But at least in Essex County, they do have a centralized county level emergency communication center, and they do have call takers and dispatchers, and they do use the card set similar to Monroe, but not in as formal a way as Monroe, which involves like a pretty structured way to enter the orders in the computer. From what we've learned, Essex is somewhat more fluid about when they use the EMD card set and when they do not. So just kind of some high level takeaways on why all of this matters for 911 diversion to 988. Obviously, in terms of a centralized versus decentralized structure for 911, it may mean multiple relationships for the 988 provider, right? So even in North Country, where there are only necessarily 4 911 centers, the 988 provider was really, working hard to develop those relationships. That's 4 different 911s, 4 different cultures, 4 different sets of leadership. And then you think about how that works in Westchester, it's even harder, right? So versus Monroe, where it's been a lot easier because the person who runs 911 talks to the person who runs 988 on a regular basis, and they can collaborate and bring their staff on board. Also really matters to think about kind of who's staffing the 911. Are these specialized call takers? Do they receive specialized call taker training that includes mental health training or not? Kind of that next bullet, what training's available to call takers or dispatchers on mental health? And then the call taking protocols. I talked a little bit about the EMD medical card set or ProQA. And those protocols vary in terms of the flexibility and discretion offered to the call takers. And I think that there are pluses to thinking about kind of what sort of protocols are being used and how that necessarily diverts calls in one direction or another. I'm happy to answer questions about that as well. I'm just going to end with a few implementation challenges, which I think are not going to be surprising to anyone. These are broader things that have come up in our research. Geolocation capabilities. So this came up as a problem for all 911 centers, and truthfully for a lot of the 988 centers, kind of recognizing the risks of geolocation and how it might discourage people from calling 988, but also feeling that it was necessary in some situations and wanting to think about ways where perhaps it could be kind of the information could be afforded to some people at a 988 call center and not others, like kind of privileged information that only supervisors would have. We haven't spoken to people since this idea of geo-routing started coming up, where they will be able to identify location. And so I'm not exactly sure if people think that might solve the problem. Still a lot of liability concerns, even as places have developed MOUs and other kind of documents and looked at the legal landscape. There are still liability concerns really at the ground level of, am I going to get in trouble for diverting a call? What if something happens? Things I'm sure you've all heard. Frequent callers and kind of how to manage frequent callers continues to be an issue for call centers, both at 911 and 988. Lack of knowledge about 988 or the 988 provider. We saw that most in North Country since it was the newest, but really thinking about kind of like sometimes they don't know who 988 is at the 911 center. So the idea that they would divert calls to them seems not realistic. I think there's still confusion about 988 versus existing crisis lines in many places and who someone should call. And then obviously there's, buy-in and time commitment for training at all levels. And maybe the most pervasive, just this still cultural differences between 988 and 911 and how to think about those and bridge those differences. So I'm going to stop there looking at the time. I'm happy to also share some other lessons learned, answer questions, but let me take the slides down so I can see everyone's faces again.
Thanks, Leah. That's great. Great to hear all that work that's being done, and venture up in North Country to see if you could find anything going on. That
Mhm.
42 different agencies out there, or how many agencies were in Westchester
Yeah.
County?
So they have 42 police agencies and 39 public safety answering points. So almost a one-to-one match. There are a couple that share. And I will be perfectly transparent. That number may be wrong. I asked multiple sources and generally was given that answer, but it's changing often.
Yeah, you might have a call taker for every frequent caller.
You could do that. That could be a suggestion, actually.
No. Well, I have a question, get us started, but I want to hear questions from everyone. What sort of information is 911 collecting beyond, say, just contact data? Are they able to talk to someone on Monday and then get another call from them on Friday and know a little bit about the case?
Yeah, so in Monroe County, for example, if it's a frequent caller, they can pull up call notes, and they've actually improved that functionality in their CAD system recently so that any call taker will be able to see call history notes like more readily. Um, but I don't think that's the case in smaller counties that aren't using such sophisticated software.
Or QA and something.
On the other hand, in smaller locations, frequent callers are generally often already known. So, even when I sat in Westchester, which is a suburban county, and has pretty big police agencies, all of the police officers I was, sitting in the training with could identify, John in this city or Mary. They know them, right? And so, they have their own ways of having information, but it's not necessarily documented in the same way.
And is this documented information private or public?
It's private, as far as I know.
It
I
is
mean,
covered
I'm
under
sure you could
HIPAA.
submit a FOIA request and get 911 call records de-identified some
You
way. But
can, but this
yeah,
is slightly medical, so I wonder whether there's some medical warehouse qualification here.
For 911, typically, depending on if 911 is separated from the EMS kind of call taking, 911 for just police wouldn't be HIPAA covered.
Mhm.
If it's a combined call center that does fire and EMS, then they would be a covered entity. So it varies, but typically some basic information about calls is public information, but they do redact generally like exact addresses of where something happened and names and those types of things.
Great. Let's hear some questions from other folks in the room.
I'm going to apologize if I'm cutting somebody off because I'm driving.
It was me. Is
Oh.
this Sam?
Yep.
You can go first. I'll hold my question.
So my question was, y'all were saying that you saw ProQA implemented slightly differently, like Monroe County ProQA, and like the standardization was pretty rigid, but that other places that use the EMD, they didn't necessarily require them to follow the format. How did y'all understand why that difference existed?
yeah, it's a great question. And again, so I think our knowledge about Essex is the spottiest because we had a really hard time getting in contact with them. So my under and so and I'm not an expert in these softwares. My understanding is in Monroe County, they've implemented the entire ProQA software as into their CAD system, which uses these EMD cards, which is an emergency medical card set. And so when they enter and they pull up the card, the call taker pulls up the card, and then the information is directly entered into the computer, and it prompts them to ask different questions and then spits out a dispatch code. Versus in Essex, where they don't have that ProQA software that they're entering for their CAD system. What they have are like literally the cards, physical cards that they can go to say, oh, this person's having a heart attack. Therefore, I'm going to ask these cards. So it's a little bit more manual as opposed to kind of the computerized system. And the one thing I will say, whether or not you're using the computer or manual, that I think is a kind of interesting challenge for the field, especially as it relates to mental health, is you have to know enough about what's going on to pull up the card, the appropriate card, whether it's the computer or the manual. So one of the things that I'll give you a good example. If someone says they have chest pains and you're a call taker, you're probably going to pull up the heart attack card or the ones that are related to that, right? If someone says they're having a domestic situation and they're giving details and it's not totally clear that it is a mental health related situation, you are very likely not going to pull up the mental health question card. You're going to enter it as a domestic incident. And therefore, you kind of bypass those important mental health questions that could be relevant and could send the call down a different path in terms of who's responding. And so to me, that's a real challenge about even these formal systems that are designed to help have call takers ask the right questions, really depend on initial context to rely on them, if that makes sense. I don't know if I was confusing, but I think you have to be able to know enough to maybe ask the mental health questions. And even a standardized system doesn't give you that context from the call.
No, that makes perfect sense. Thanks.
Yeah.
Other questions? Mary.
Yeah, I do have a question. I've been trying to formulate it in my head because there's kind of bigger picture ideas, but there is a concrete question I have around in your initial focus groups. Well, one thing I was hearing you say was just that around the idea of safety and safety concerns, that being pretty clear cut with 911 and the crisis call takers, and it being a little vaguer with users of these call centers that you spoke with. And I'm curious if you saw any like trends or had any crystallized thoughts around how that looked different when it was a first or second or third party caller, that someone who's experienced a crisis themselves versus calling on behalf of a loved one versus it being a stranger that they saw. And if you saw a difference in how folks were framing safety concerns and how that could impact, where a call ends up getting routed or who someone ends up calling.
Yeah, it's such a good question. I think it's a real challenge. I think that I don't think we have great data on it because our numbers are small. I will say that the consumers were the ones who had like the highest bar for calling 911, right? They were the people who used the life or death. Like they would rely on 988 for many more things than I think family members or certainly third parties would. Some of the family members, had experiences calling 911 that they said, they felt they weren't necessarily suicide related calls, but they felt ill-equipped to handle them, and feared for their own safety and therefore like would still call 911. So I think there's like a cascade of kind of level of comfort with 988 as a first line response based on where people sit, which makes kind of intuitive sense. But I think we would need to do more work to really understand.
Were there any already existing consumer warm lines or crisis lines that didn't extinguish after 988 got started?
Yeah. So in all of these places, they have kept their existing crisis lines and warm lines. And they've been they've done that intentionally. And I would say, I think for now, it makes sense for a couple of reasons. And I'm happy to get pushback on this, but my feeling is twofold. One is people still don't really know about 988 everywhere, right? So we don't want people to like call their line that they know and feel like, wait, what happened to my line? And you're sending me to this line, right? And then the second is, in some of these locations, people do have existing relationships with the crisis lines. And so if that was me, I would want to still call the people I know rather than calling an anonymous source. And then I guess the third, which I just thought of, is we still haven't sorted out, exactly where your call's going. So for me, I have a Boston-based cell phone. I live in New York. My 988 call is going to Boston, which does not do much help for me. Like it would make more sense if I called my local crisis line. But I do think all of those things, until we work out, getting people to the right place, we should keep the options open. That's my perspective.
And another idea is that you might not want to change your area code if you like your if you're a frequent caller and you like your call taker and you've got built a relationship with them. And that seems to be a lot of what warm lines and these 988 lines are going to be, is people will accumulate that will be the level of care that they select. Is the frequent callers, this sort of accumulation of those taking over all the time? Is that a concern?
Sorry, by your question, do you mean like frequent callers kind of clogging up the lines, or?
Well, clogging is kind of, I didn't want to use that word, but you know what I mean.
Yeah. I don't, that's not a concern I've heard. I think there's always the concern about frequent callers and resource constraints, but not to the extent of not necessarily being able to serve other people. At least the call centers that we spoke to have pretty, well-defined processes for how they manage frequent callers, particularly if someone's, calling multiple times a day. Many of the call centers will tell them that they need to stop calling for that day.
We've just got a couple more minutes. Does someone have a last question?
I see a couple in the chat. So Sally, I'm going to go in reverse order. So Sally said that 911 is piloting co-locating 988 call takers at their center. Yes, I've heard of that in some places, Sally, and I agree that I think it could be very useful. Just in terms of building trust and like knowing where your call would be diverted to. It's, next door. And then Mary's question is, have any of the communities attempted to improve interoperability? Yes, I think, in Monroe, for example, they have specific language around what calls should be diverted and vice versa. But I think there's the legal and structural, like, this is what should happen, and this is how we're going to collaborate. And that is an important step. And then there's are people actually using it, right? So can you transfer the call? Do you have the technology to do so? Do you have the go ahead and the formal things that you need in place? And then is anyone willing to do it? Or does anyone know they're supposed to do it? And that seems to be a longer battle, right? So when I followed up with Monroe at some point during our process, I was like, that's great. You're really ahead of the curve. You can, transfer these calls back and forth. Are any calls being transferred to 988? And she was like, nope. So.
Callie had a question.
Comment. Just closing the thoughts from the familiar voice conversation.
Yes.
Is really interesting, because I know that back in the day, when we were just kind of, most of our traffic was on Colorado Crisis Line, we had those learning moments where lines would crash because people were very resourceful, right? Calling in on multiple Google numbers, texting and chatting all at the same time. And all of a sudden, resource allocation is dedicated towards this one caller who is, again, just like, I don't know how to do any of that. So very, very intelligent resource seeking. And so you don't hear about that as much yet. And so that'll be really interesting, because I do believe that we will see the emergence of like a different kind of crisis clinical structure for that telephonic interaction. We already had like kind of different familiar voice programs on our line that we implemented. So just an interesting future.
Yeah, I think that it's a really good point, particularly as, again, kind of thinking about what maybe was like contemplated as who's calling, was going to call 988 and then who's actually calling 988. I think you see a lot of lower end severity and a lot of frequent callers in a way that maybe wasn't contemplated enough.
Sally has a question.
I just wanted to layer on to, and I'm, by the way, the least knowledgeable person here, so don't pay too much attention to what I say. But according to the 988 director, who is part of the Transform 911 project, who's co-located the 988 folks, some benefits have been, as you mentioned, Leah, but I just wanted to add one on, is the trust building with the 911 call takers. Oh, you do know what you're doing. Oh, you actually do have resources that matter. Oh, I don't have to be as nervous. But the secondary benefit has been the mental health care for 911 call takers, because that's a really, really hard job to be hearing those calls all the time. So it's sort of a learning and trust building step that she feels optimistic about.
Yeah.
Our traumatized workforce. It's really an untapped, unmeasured benefit of co-responders as well.
Yeah.
Well, thanks everyone. This has been great. Thank you, Leah.
Thank you, guys.
Thank you, Amy. Thanks
Look
for your
forward
work.
to
Thanks for your writing.
conversation.
Thanks for getting us all in
Thank
a
you
room
all for
together.
the work you do in the field. So important.